Good afternoon, everyone. Welcome to today's session in our continuous series on person-centered respectful maternal care. I'm going to hand over the session to Dr. Christine Muse, who is going to chair the session and bring on board the various presenters that we have. Specifically, today's focus being optimizing approaches for including self-injection in the suite of family planning options. The ICAN project. So Christine Muse is Deputy Director of Nursing Services at Kenyatta National Hospital. She's been involved in a number of researches and projects in the hospital, and she will be chairing this session. She's an author, she's also a preacher, very diverse. And we welcome you, Christine, to take over the session. Karibu sana. I'm Dr. Karingo from Kenyatta National Hospital. Karibu, Christine.
Thank you, Dr. Karingo. Welcome everyone again. We are happy to have you here. And in this session, our first speaker is Julia Kramer. This is a designer, practitioner, and researcher with experience at the intersection of equity design, and global health. Her research investigates design approaches to support social justice and promote equity, particularly throughout the development and implementation of products, services, and systems that improve access to health. And she focuses on low resource settings. She also studies and teaches human-centered design projects and supports diverse participation in equity-oriented work. Currently, she's serving as a director of human-centered design for innovation, for choice, and autonomy. And this is for the last 4 years. And she's also involved in the implementation research project in Kenya, Malawi, Nigeria, and Uganda. And she has done a lot of work on problem solving and implementation of self-injection of DMPA and SC within a full basket of contraceptive choices. And Dr. Kramer, we are happy to have you. She also holds MPH, and her PhD is in mechanical engineering, and this was obtained in the University of California. Highly welcome, Dr. Kramer. It's a pleasure to have you take this session.
Great, thank you, Dr. Muse. Let me go ahead and share my slides. 1 second, please. All right, are you all able to see my slides here?
Yes, we are.
Okay, great. Well, good afternoon, everyone. My name is Julia Kramer. I'm excited to get the chance to frame the webinar presentations that we have today. Like Dr. Muse mentioned, I'm the Director of Human-Centered Design for the Innovations for Choice and Autonomy project, or the ICAN project. And today I get the pleasure to introduce our ICAN team's work on optimizing approaches for including self-injection of DMPA-SC in the suite of family planning options. And so what I'll present today includes an overview of the ICAN study, a discussion of person-centered contraceptive care, an introduction to human-centered design, and an overview of how we're applying human-centered design in the ICAN study. So the ICAN consortium includes researchers at Akina Plus Health in Nigeria, Makerere University in Uganda, Kenya Medical Research Institute, the Malawi University of Science and Technology, and the University of California in San Francisco, which is in the US. And our project is funded by the Bill and Melinda Gates Foundation. We're a 4-year project and we just wrapped up our 2nd year, so we're about halfway through. One of the questions that guides our work in ICAN is how can self-injection of subcutaneous DMPA be implemented in a way that best meets women's needs as they themselves define them. And so let me just take a step back to introduce what is subcutaneous DMPA. It's a contraceptive method with the same active ingredient as intramuscular DMPA or depot, but it comes in a pre-filled all-in-one injection system. It has a lower dose and a smaller needle. And so the form factor of DMPA-SC enables the option for DMPA-SC users to actually self-inject instead of going to a provider for injection. Both DMPA-SC and IM are safe, highly effective contraceptive methods. Both are delivered every 3 months and both have comparable side effects. But the ability for women to self-inject with DMPA-SC gives rise to the second question that is guiding the ICAN work, which is, can self-injection enhance contraceptive agency for women who face the most barriers? We have a lot of activities in the ICAN study, including qualitative research with women, intervention design and evaluation, developing and validating a measure of agency, and a longitudinal cohort study. Today, we're just focusing on the intervention design part, but wanted to give a scope of the portfolio of work here. The aim in our intervention design work is to design and evaluate approaches for introducing and supporting the use of DMPA-SC for self-injection in the context of a full basket of contraceptive options, and that's across public, private, and e-commerce channels. Person-centered contraceptive care is a foundational pillar in the ICAN study. And to set the context of what I mean when I say person-centered, I can define what it means first. So patient-centeredness is providing care that is respectful of and responsive to individual patient preferences, needs, and values, and ensuring that patient values guide all clinical decisions. Person-centeredness extends this definition by recognizing the role of factors outside the healthcare system that influence an individual's health needs. And person-centeredness has implications for what we design and how we evaluate it. So for example, a person-centered approach might focus on designing a program that increases the number of people who can make and act on their own contraceptive decisions. This approach prioritizes people's well-being and their positive experiences with care. On the other hand, an approach that isn't person-centered might focus on designing a program that increases the number of people using contraception. And this may prioritize preventing unintended pregnancy at the potential expense of people's autonomy and choices. And so how this looks in the ICAN study is with this person-centered viewpoint, we're aiming to support women's contraceptive decisions, whatever they may be, and aiming to support women's ability to navigate contextual factors as they make and act on their contraceptive decisions. We are not working to motivate women to uptake contraception regardless of their preferences. And person-centeredness is a human rights-based approach to family planning. And this rights-based approach focuses on the rights of individual and couples to decide freely and responsibly the number and spacing of children with quality sexual and reproductive health information and services to be able to do so without facing discrimination or inequality. And so as people go about their daily lives, they interact with the healthcare system at different points and in different outlets, whether that's clinics, pharmacies, hospitals, or even online. And so around them, they're living within the context of their community and family, their policy and health systems, even the historical, social, political, and economic forces that are impacting their lives. And as we think about how to best meet people's contraceptive needs, and how to make contraceptive services available and accessible to people, specifically in the case of ICAN, introducing a new self-injectable contraceptive method, it's critical we recognize this broader context within which people are living their lives. And so to do that, human-centered design is one approach that we can take to understand the impact and the influence of those contextual factors on the lives of people. So there's a really rich academic field of study dedicated to human-centered design. And this quote comes from a human-centered design researcher who states that human-centered design is fundamentally an affirmation of human dignity. It's an ongoing search for what can be done to support and strengthen the dignity of human beings as they act out their lives in varied social, economic, political, and cultural circumstances. And so we can see already the links between human-centered design and person-centered contraceptive care. You know, conceptually, both are putting people or humans as the priority. Both are concerned with the promotion of human rights, and both require an understanding of the context in which people are living their lives. So I've mentioned human-centered design a lot here without yet defining it. So let me define it. Human-centered design is an approach to understanding stakeholder needs and desires towards the creation of novel interventions of value. And so it's both a process and a mindset by which we can aim to create solutions that are desired by people, technically feasible, and viable for implementation. And so this human-centered design process broadly has two phases. First, diagnosing what the problem is, and then identifying the solutions to the problem. So we start with an initial understanding of the problem, and then we conduct broad research to try and understand the different needs and contexts of stakeholders within that. We then narrow in to analyze the key needs, define what the specific problem we're aiming to solve is, and then go wide again to generate a broad range of divergent ideas, and then narrow back in as we're creating testable prototypes to narrow in on our potential solutions. We're then testing and iterating, moving back and forth in this process of our prototype solutions, eventually working to create a solution that then we can launch for further testing and evaluation. And so there is a lot of iteration back and forth in this process. We might cycle through these steps multiple times before we're ready to launch that solution for further testing. And so with that overview in mind, I'll just preview how we're applying human-centered design in the ICAN study, and the rest of the speakers we have lined up today will dive into the specifics of what this looks like in each of our ICAN study countries. So we're applying human-centered design to create new person-centered approaches to support the implementation of self-injected DMPA-SC. And we formed these co-design teams in each country. Each design team includes researchers from each study country and from UCSF, includes implementation partners in each setting, and includes community members in each setting. And so our goal in bringing together these four groups of people is that we're pairing research expertise with implementation expertise with lived expertise as we're going through this creative process together. And very briefly, here are the design challenges that we're taking on in each ICAN study country. So in Malawi, we're tackling the challenge of how might we support health surveillance assistance to better meet women's contraceptive needs, including decision-making around and use of self-injection. In Uganda, we're tackling the design challenge of how might we leverage relationships and social communication outside the healthcare system to support women in making and acting on their contraceptive decisions. And finally, in Kenya, we're tackling the design challenge, how might we improve access to DMPA-SC and other contraceptive methods through an e-commerce platform. And so one thing I want to highlight across all these design challenges is that we're trying to frame them from a person-centered point of view. So instead of focusing on, how might we improve uptake to self-injected DMPA-SC, we're instead focusing on how might we improve access or improve support for decision-making. So this is one of those places where that human-centered and person-centered viewpoints become really important. And today we have the chance to highlight our ongoing design work in Malawi, Uganda, and Kenya. And the design process in each country is in a slightly different phase. So first we'll hear from the Malawi team, who's in the thick of their design research and analysis. Then we'll hear from the Uganda team, who's in the process of creating tangible and testable prototypes that we're preparing to launch for initial testing. And finally, we'll hear from the Kenya team, who has wrapped up this initial design process and is now preparing for program evaluation. And I'll just close by sharing this quote from a designer in the US who I really admire, Antoinette Carroll. She says that systems of oppression, inequality, and inequity are by design, and therefore they can be redesigned. And so as we're all working to address health inequalities and health inequities, we can take hope that the existing oppressive systems can indeed be redesigned towards more person-centered and equitable outcomes. So thank you all for your time and attention for this opening talk. And thanks to the rest of the Rockstar ICAN consortium teams, not all of whom are able to join today, but who I'm happy to be able to represent. I'm very excited for you all to hear from the rest of our speakers.
Thank you very much, Julia Kramer. I think it was very clear. And now we know what we are doing today. My take is that we are looking at personal-centered approaches when it comes to self-injection contraceptives, and each country was doing something different. And therefore, our audience, as we move on, we appreciate what Julia has presented to us. We also appreciate the work that those countries are doing, and we are looking forward to what is going to come through. As we proceed, we are going to have the Malawian team, and the presenter is Emas Potolani. Emas Potolani has spent 5 years facilitating different processes in development using intervention design with a wide range of stakeholders. He has worked with Malawi, Senegal, Rwanda, and Morocco, and he is currently facilitating human-centered design approach with the Malawian University of Sciences and Technology in collaboration with the University of California, San Francisco, and the Innovation for Choice and Autonomy. Previously, Emas trained COPS Africa volunteers and communities in Malawi and Rwanda, and in building community resilience in the COVID-19 pandemic that we've just been having. And he was utilizing HCD mindsets to spark community-led efforts to help them to improve their livelihoods. Emas also works with root cause. This was between 2017 and 2020. And here he was working with a social innovation lab field manager in a USAID-funded local works initiative in Malawi. And therefore, Emas, highly welcome to take this session. Thank you.
Thank you so much. I hope you can all see my screen as I'm sharing right now.
Yes, we can.
Thank you so much, Dr. Julia. Thank you so much, Dr. Julia, for the wonderful introduction, as well as an overview of our work that we're doing. As you have heard, my name is Emas Potolani, and I'm one of the human-centered design facilitators in Malawi under the Malawi University of Science and Technology, MUST. And today I will take you quite briefly on our highlights, focusing more on how we are leveraging community healthy workers, HSAs, as they are called, to innovate access to self-injection among women in Malawi, including their decision contraceptive use. We are focusing our work in 2 districts, one in the southern part of Malawi and another in the central part of Malawi. So to continue, I wanted just to give you a highlight of who we are working with, who is participating in our work. As you can see on your screen, the ICAN Malawi study is collaborating with another stakeholder, a broader range of people, ranging from the Ministry of Health, who have been a key stakeholder in our work, showing interest from the start. The MUST team is a team from the University of Science and Technology leading the work. but also the family planning champions, design teams in both districts, community gatekeepers, women who are using Cyana, but also some other contraceptives, but also women that are not using any of these self-injections, and other stakeholders as highlighted. I'll take you to who exactly we are working with in our design work. So coming from a broader range of stakeholders that the project is working on, we want to make sure we are designing together. So we have two design teams. So one design team up in the southern Malawi and another in the central part of Malawi. So in the design teams, we have the community advisory boards that are formed part of the design teams, also representatives from the district level health facilities found in Mulanje and Chise. The faith community says they are representative to the design team as well. The chiefs, who are proven to be some of the powerful and most influential forces, stakeholders in our process, but also the Minister of Health, even at national level, who are participating quite with wanting to make sure that it's been to see their work. So these are the people we are working with, and how do we start our work? So at the beginning of the year, we wanted to make sure we remind ourselves as we entered into this phase 2 of this project. So we had to conduct our refresher trainings. In the refresher trainings, we worked with a team from MAS, but also a key meeting stakeholder in the Ministry of the Health, especially from the Directorate of the Reproductive Health Unit itself. So we looked at mindsets that the HCP processes also interestingly how to make sure that all participants in this training can learn by doing. So we can expose them to go to nearby health centers where they have to observe, but also immerse themselves in the daily work of the healthy surveillance system. Things that are happening in to actually apply the mindset. So after that, we also went ahead to do our 2 initial HCP trainings.
Hello, Emma, we are not able to hear you. Hello, Emma, if it's possible, maybe we'll need to go back a bit. We are not able to hear you.
I lost the network a little bit back now. I'll continue. So I think in the initial
Emmas, there's a lot of hi, Emmas. There's a lot of echo, a lot of noise in the background.
Can you hear me? Oh, sorry.
Yeah, we've not clearly heard.
Is that coming from? Can you hear me now?
From slide 4. If you can go back to slide.
Okay. Okay, all right. Let me do that. All right. I hope you're able to hear me without any background noise. I'll quickly continue.
Go ahead.
With the, thank you so much. Our HCD refresher training mainly focused on making sure the maths team is taken aback with of HCD mindset, but also our key stakeholder, which is the Minister of Health, who has been so interested in our partner that's been part of our leading. So we conducted this together with them, going through the HCD mindsets, but also giving them an opportunity to immerse themselves in a training which made them so going to the health center in the city to practice the HCD mindsets so that they can remain aware of that. So I'll quickly go to how we did our initial trainings in our two sites, South of Malawi and Central Malawi. So the same training that we conducted for stakeholders in the city, we also conducted two of these separately with stakeholders there to introduce them to human-centered design. This is a new concept in doing things, so we wanted to make sure that everybody is aware and they also have doing that. So we introduced human-centered design to the chiefs who are part of the design team, but also some of the women that are using, but also the non-users and other stakeholders altogether. One important key here was that we did all these trainings in the districts in the local language, so we can capitalize in making them that they learn and understand how our process will be going, because we want to collaboratively design together with them the solutions that we are going through in terms of accessing contraceptions, but especially also the storage. So our key here in our research is to make sure we emphasize on empathy. If we really want to know the issues women are going through, if we really want to know how best we can work with health surveillance assistants, we need to be in their shoes. So that's why you'll be hearing me highlighting more on getting to be working with these people in the community, but also designing together. So how did we set up our research work? Basically, I think I've been talking about our designing efforts. So we are collaborating with the SI users, the non-users, the Ministry of Health, community health workers, and other critical stakeholders like chiefs, faith community, and everybody else in our work. We have two design teams, like I mentioned, who are capitalizing on our processes, maximizing participation of our communities and people that are involved to make sure that our design solutions are indeed person-centered in that. And this, as it is right now, highlighted as I'll be going to the end, is going on quite interestingly, that we are collaborating with our UCSF team and the Malawi team together to look at the insights that is coming from the field, analyzing the insights and framing our problem to make sure we are able to stay on top of the game in understanding these issues. But also, our research is being done right now. So right now, our research team is in the field. They send their research work, the data that is being collected in the research, so that our analysis team can do that. I'll highlight quickly what we are learning so far from this process of analysis. So right now, we're in the stage of doing the analysis, so whether we can move towards an advanced stage where we can begin to ideate possible solutions that we can address the issues that women are facing, but also more on how we can capitalize on the availability of the community health workers in the community. So our key interesting learning is on collaboration. When we work together with women, when we work together with chiefs, community gatekeepers, when we work together with community health workers, we are seeing that people are trusting the process and they are able to appreciate the process. But also, the Ministry of Health is involvement in our early stage rollout has been key in making sure we get buy-in from them, but also support from the government itself. We are all more positive that as we'll be going, we think they'll be able to implement with us more and support this work even again. Also, when we are in trust, the community health workers are more close to people in the community, are trusted by women, but also by communities. I think because they are more close and the first that people can relate with what they are there, and this is very helpful in us helping to see what solutions we can actually innovate around maximizing their usage. Another interesting learning in science class is the level of expression in our study. So almost everybody consider contraception and family planning to be an interest by women. But what we are seeing is that currently women are actually more interested that their spouses and husbands be also trained, and they make use of that training so that women, husbands can learn on how to inject their women or their wives, so that I think together they can participate in self-injecting and also promote the usage of contraception. But also, an interesting thing is that I think that Julia mentioned, right now is still in analysis phase. What we have done with our analysis is to start analyzing the data as it comes. We don't wait until the end so that we can accumulate the data and analyze it. We are learning that I think it is important for us to utilize the data as comes. It is giving us an opportunity to probe more in some of the areas that we are getting some of the myths that are coming from the community, but also some of the cultural dynamics and beliefs and values that women are voicing out, that men are voicing out, why they don't participate in decision making in family planning. So this is giving us an opportunity for us to do a back and forth with our research team as we shape our work going forward. So maybe just to take you through again on where we are and where we're going. During inspiration phase, we're discovering challenges that are coming that women face in accessing self-injection, but also some of the stories, the insights that are getting from there, like the trust that is there between women and health surveillance officers, like the buy-in that we're getting from government at this stage. So this is going to help us as we'll be framing our problem so that we can actually define well what our problem is as we move to our prototyping phase, and then we can test some of those innovations together with our design teams, together with the community stakeholders, as then we end up in implementing those innovations. As I finish, I wanted to thank you for listening. I wanted to highlight that it's been an interesting journey to learn some of the things that we had our assumptions on in terms of how decisions are made by families or by women. It's an interesting journey, and our ICAN project is exposing a lot. We are continuing to research in the field, and we hope to build innovations that will address the issue that women face in accessing family contraception, as well as self-injections, and more also highlighting on how we can use health surveillance officers that are already in the community in making women access it. Thank you so much for listening, and I'll be looking forward to address some of the questions, feedback, and comments after this. Thank you so much.
Thank you very much, Emmas. That was a great presentation. We have a few challenges with the voice, but we've been able to take a few things. We've picked the personal-centered approach. We've also picked the aspect of the importance of partnering, building those partnerships with the different stakeholders. We've also picked the idea that you needed to diagnose, and then you look for solutions for the problems identified. We've also seen the important part that the participants are playing and the collaborations that you're building, and the fact that when the spouses said they wanted their husbands to be trained, you've also picked that in, and the fact that you are out to look for surprises and leverage on them, it's a big plus, and we really appreciate that presentation. We're looking forward perhaps to getting the slides so that where we had challenges with the voice, we will be able to fill the gaps. Now we need to move on with our webinar, and our third speaker is going to be from Uganda. This is Phoebe Alitubera. Phoebe is a researcher fellow, and she's focusing on reproductive, maternity, newborn, child, and adolescent health. She has also been focusing on health policy, planning and management department, and she is based at Makerere University School of Public Health. As we receive Phoebe, I want to communicate to the audience that if you have any questions, you can write them down in the question and answer area, and we'll be able to respond to some as we move on as much as possible. I can already see one question there. We'll be able to respond to you, Alex Kilonzo. At this time, it is time for you, Phoebe.
Good afternoon, everyone. I'm Alitubera Phoebe, the project director for ICAN Uganda. Please let me know if you can hear me.
Yes, we can.
Okay, thank you. Yes, I present to you the human-centered design process to support uptake of DMPA-SC in Uganda. So preliminary research of DMPA-SC self-injection in Uganda revealed that many of the women had learned about DMPA-SC through peers, and that social communication is an important avenue for creating demand for DMPA-SC. So this is an illustration of how that social communication plays out in the daily lives of women as they go about their chores. Therefore, for this human-centered design work, we wondered, how might we leverage relationships and social communication outside the healthcare system to design appropriate community-based interventions for offering DMPA-SC in Uganda? We began with research in the study districts of Mayuge and Oyam to understand women's family planning needs, challenges, and experiences in social groups. Our respondents were sexually active women aged between 15 to 45 years, who are part of women's groups, including the women leaders of these groups. The key stakeholders we interviewed were district health team members, health workers, and village health team members, also known as VHTs. We obtained data on participants' knowledge and experience of family planning use and access, daily life influences, and information channels. We collected data through 21 in-depth interviews and key informant interviews, 5 focus group discussions, and also observed 12 women for their day-to-day activities. After we analyzed the data, we developed several artifacts, including personas, journey maps, and ecosystem maps. Personas represent common and memorable characteristics among the women, while the journey maps represent the path taken by a person to interact with a service or a product and from the user's perspective. So this is Mary, a 37-year-old single mother of 3 who owns a restaurant. She has a boyfriend and is sexually active. She self-injects with DMPA-SC, which she accesses through a VHT. So for this journey map, the red dots reflect frustrations, while the green ones reflect opportunity points. So on a typical Saturday, Mary closes her restaurant and heads home. On Sunday, she prepares an agenda for her gender-based violence support group meeting. The agenda of the meeting is an opportunity which we can use to include family planning as an agenda item. Mary leaves her children with her neighbors and goes for the meeting. At the meeting, they discuss ideas to become financially independent. This is also another opportunity point for us to discuss family planning in detail and for the women to share their lived experiences of family planning with each other. One of the members shares that her recent fight with her husband was because of her use of an intrauterine device. This is a frustration for most women, and most men need to learn about family planning and be involved in family planning services. The family planning discussion reminds Mary that she is due for her next injectable contraceptive dose, but she does not have any more stock at home. Mary decides to pass by the VHT's place on her way home. The discussion about family planning continues, with many group members sharing frustrations about family planning use, key among which is lack of partner support, forcing many of them to discontinue use. Lack of partner support is a common frustration among women. The meeting ends with collection of contributions towards burial arrangements for a group member's sister. While heading home, Mary passes by a shop where she meets her aunt, who is angry about her separation from her husband, and confronts her about it. Mary, who is distressed, meets Sarah, a friend, and together they decide to walk to the VHT's place. However, on getting to the VHT's place, there's a long queue and they have to wait for a while. Long queues at points of health service frustrate women and impede services utilization, including family planning. As they wait, Mary, who has experience from using various family planning methods before, shares basic family planning information with Sarah and encourages her to inquire for more information from the VHT. Such discussions between women are an opportunity for us to share family planning information and experiences. The VHT calls the district health officer to inquire about stock availability of self-injectable contraceptive and is informed that it will be available in 2 weeks and informs Mary accordingly. Mary then asks the VHT for an alternative contraceptive option in the meantime, and the VHT gives her condoms. Family planning commodity stockouts are a major frustration among women and often impede achievement of their family planning choice, but also result in family planning discontinuation. So this is the ecosystem map, and basically we have to be cognizant of the environment in which our target population exists, including the structures, the people, and their importance. So we developed ecosystem maps to illustrate these and to guide the human-centered design process. Mary is motivated by her children, and her decisions are influenced by her boyfriend. She receives support from her neighbors and also relies on information from health workers, community leaders, and her peers. Family planning stock fluctuations frustrate her. So while I've only showed one persona, and that is Mary, and her journey map and her ecosystem map, we developed several of these for our human-centered design research to be able to capture the different experiences women had. We also developed insight statements to point us to what needs our future solution should address for the women.
Phoebe, you're falling.
Hello, can you hear me?
Yes, we
Hello?
can hear.
Okay, then I'll continue. So, insights regarding decision-making and use. Many women seek partner permission before using family planning. However, most men do not support family planning use, and the women desire more male involvement in the family planning service delivery. Then we also found that family planning services are free in public health facilities. However, family planning commodities are often out of stock, and the women desire consistent availability of family planning products. Then most of the information on family planning is delivered by village health teams and health workers in group settings. However, many of the women also get information from their peers. They desire to receive family planning information on a one-on-one basis with the healthcare workers rather than in a group setting. Some women are stigmatized for seeking family planning services due to their standing in the community, such as being divorced, being a sex worker, being an adolescent. So they desire services that are supportive and are private. Some women experience negative health worker attitudes when they seek family planning services, and they desire respectful and supportive services. Following the research, we then formed 6 design teams, which include the Makerere University Central team, that includes the principal investigator and the co-principal investigators, the project director and the field coordinator, the UCSF team, and then for each of the 2 study districts, we developed 2 teams. And these included women who are part of women's groups, leaders of women's groups, members of community-based organizations, and then research officers from Makerere School of Public Health. People from community-based organizations bring on board a wealth of experience in health programs, many of which target women using community engagement strategies. We then moved into the idea generation phase, during which we came up with solutions to various key needs identified during the research phase. For each specific problem, we developed a how might we statement to clarify what we needed to do. So the first, how might we communicate availability of contraceptive methods at various access points so that all women have consistent access to contraception? How might we encourage and equip social groups with factual and relevant family planning information so as to support women in making and acting on contraceptive decisions? For the third, how might we support healthcare workers with the time and resources they need to provide high quality and confidential support to women seeking family planning? And finally, how might we increase male involvement and acceptability of family planning so as to encourage adoption and continuation of use among women, families, and even households? This picture is an illustration of the ideation phase we undertook, and through workshops, each design team had a session of individual brainstorming to come up with various ideas on how to solve each of the how might ways. We then collected and refined the ideas and integrated them into a solution for each problem. So following consolidation of the ideas, we managed to come up with 5 final solutions.
Phoebe, you're not audible now.
Okay. Can you hear me now? Is this better?
Yes,
Yes, we can hear you.
Okay.
We can hear you, Phoebe. Go ahead. Please go ahead, Phoebe. We could hear you.
Sorry, I had muted. So our first idea is champions for family planning information dissemination. Our second idea is male family planning talk show combined with other male topics of interest. The third is to create safe spaces to provide family planning services to women. The fourth is to incentivize potential family planning users. And the final one is to communicate availability of family planning products. So after this, the Mayuge and OYAM design teams then ranked the consolidated ideas based on their feasibility and ability to address the project focus of leveraging social communication outside the healthcare system to support women in making and acting on contraceptive decisions. Following that voting, we carried forth 3 ideas, and the first is champions for information dissemination, and then creating safe spaces to provide family planning services to women, and then communicating availability of family planning products. So we only went ahead with the 3 that are in bold. We then refined these ideas into simple low technology prototypes that aim to support women's contraceptive agency, but not necessarily the use of contraception, and also have a special focus on self-injection of DMPA-SC because it is so novel. So this is quite busy, but I'll just give you a run through. The first prototype of using low technology to communicate family planning stock availability. Here, the VHT receives information about stock availability of family planning commodities, either from the Health Facility Notice Board or from the stock manager directly. The VHT then shares this information via SMS with women's group leaders and other key community members. Then these people share with women in their groups and women within their communities. The VHT also shares the information through printed messages at strategic locations and through a megaphone, and can even do a radio announcement. So for the second prototype of creation of family planning safe spaces in several locations, we did it to cater for both men and women. So for the women, these safe spaces will cater to privacy needs, especially for vulnerable groups such as adolescents, sex workers, and women whose partners are strongly against family planning. They will be in locations agreed on by the women, and these would range from someone's home to a salon or a lodge. The space will have a designated trained family planning service provider who will have a schedule that is known to the women. For the male safe spaces, they will take into account where men are most comfortable. Places like bars, border stages, or even car garages. And here they will be met by a family planning service provider who will share family planning information. For the final prototype, it was to provide family planning information by family planning champions. The champion can be a health worker or a reputable person in society selected by the community members themselves. This person is then trained on family planning and given materials to conduct trainings within their community. So just a disclaimer, our current prototypes are really interesting and creative, but currently they don't combine into one holistic solution. So we are still working on them and refining them. Our aim is to have the eventual solution to cover all parts of a woman's contraceptive journey. So following finalizing the prototypes, we shall test them, refine them, and then we shall implement and evaluate. Thank you.
Thank you so much for that very comprehensive presentation, Phoebe, on the work you're doing on the ICAN project in Uganda. We are now going to go over to our third presentation, and thanks to our participants for staying with us. We are going through the ICAN project and using the use of self-injection in the suite of family planning options and just what has been going on in the countries. We've had a presentation from Malawi, we've just had one from Uganda, and now we are going to hear from Kenya, from Dr. Sarah Gitome. So Dr. Gitome is a medical doctor and public health specialist at the Kenya Medical Research Institute, KEMRI, with over 13 years of experience in designing and implementing HIV prevention and reproductive health related research in Kenya. Her main research interests are at the intersection of HIV prevention and reproductive health, particularly among young women and reproductive age discordant couples. She is the co-principal investigator in the Kenya study team, carrying out 2 human-centered design-based studies to optimize provision of DMPA-SC and other self-care products through the e-commerce and pharmacy retail channels. She is passionate about ethical conduct of research in Kenya and serves as a member of the KEMRI IRB. Karibu sana, Dr. Gitome. Please take over.
Thank you very much, Dr. Muse, and good afternoon, everyone. Thank you for this opportunity to share our research experience carrying out this human-centered design work, which has been a very exciting project being carried out, as Julia articulated, being carried out in 4 different African countries. So in Kenya, we're focusing on provision of self-injectable Depo-Provera and other self-care products through the e-commerce channel. And as Dr. Muse has mentioned, I am the co-principal investigator on the ICAN Kenya team. And I'm presenting this on behalf of our ICAN Kenya colleagues. I believe some of them have already joined the webinar and others are out in the field doing various field activities. But please receive greetings from the whole team. So Julia has already talked about who the various team members are from the different countries. And so I just wanted to share that again with you, that in Kenya we have Prof. Elizabeth Bukusi, who is the PI on the project, and then myself as the co-PI. And we have 3 co-investigators based in Kenya, that is Dr. Kwena, Dr. Muga, and Dr. Ndunyu, who is based at Maseno University. And then, of course, our collaborators from University of California, San Francisco. I will not go over this because I think Julia covered this very well, except just to say that in Kenya, our implementing partner is Kasha, which is an e-commerce platform. And the rationale behind partnering with Kasha was informed by the fact that research shows that the private sector forms a significant source of contraceptives for many women. As you can see on the chart to the left, they serve slightly over a third of the women who are accessing contraceptives. And some pharmacies are currently stocking and selling the self-injectable DMPA-SC, that is the subcutaneous formulation of Depo-Provera. The regulations have recently been changed, as some of you are aware, to allow pharmacists to provide a wide range of contraceptive products, including injectables. So the plans are underway to roll out the training of pharmacists so that they are well equipped to provide injectables, including the self-injectable contraceptive. So Kasha comes in the sense that as an e-commerce, what they provide or what they stock are women products and baby products. And amongst the women products, it's a full range of beauty products, health products, contraceptives, and they do sell contraceptives, including DMPA-SC. Of course, the person has to provide a prescription for that. So because Kasha is an e-commerce platform, it operates slightly differently from most pharmacies, which are the traditional brick and mortar shop where you go in, you speak to a provider, and then you get your contraceptive or your products. For Kasha, it's more of it's a digital platform, and you have what we call a direct consumer mechanisms, where you can have a product that is already approved for self-care or for self-administration. One can go and purchase it directly from Kasha and they use it. So that's what we call the direct to consumer mechanisms. And what we were trying to see is whether these kinds of mechanisms through an e-commerce platform can help reduce the barriers that women face when they have to go to a health facility or to a pharmacy to access their contraceptives. So what we sought to do was, as Julia mentioned, was to see how might we expand, how might we improve access to DMPA-SC for self-injection, as well as other contraceptive products through the e-commerce platform. And we're doing this through the human-centered design approach, which already the previous speakers have talked about, the various steps that we have: a formative research step, then you analyze the data that you get, Then you have a session where you're generating ideas and developing those ideas into prototypes. So we'll walk through what we did for the Kenya Design Challenge. And we started off with formative research, which we conducted amongst women of reproductive age who were defined to be 18 years and above. And these are women who are current or potential users of Kasha. So not all the women had used the Kasha platform to purchase products. And Kasha does provide their services through the website as well as through a USSD platform for those who don't have smartphones or don't have access to a device that can go onto the website. Then we also carried out our research amongst Kasha staff and service providers, and then stakeholders and key informants. So for the Kasha staff and service providers, we conducted observations. We just shadowed them during their day-to-day work for a period of time, about 4 hours, in the various departments. So they've got customer care, they've got the pharmacy, they've got the people who fulfill orders, and we shadowed them in their various stations of work just to see what their experiences were, where they were facing frustrations or where there were opportunities to improve on the services that they're providing to the women. And then we also carried out in-depth interviews. For the Kasha users, the observations focused on their experience when they are accessing the Kasha website, trying to find out, first of all, is it easy for them to use the website? Are they able to navigate and find the products that they're looking for? Are there points where they're frustrated? Are there points where it's relatively easy for them? And then there's the interviews, the in-depth interviews now came to augment the information that we're getting through the observations, just to really understand what are these frustrations that they are facing. For stakeholders, these were key people in various organizations that are involved in contraceptive care, or people who have in one way or another are involved in the DMPA-SC value chain. So what did we learn from this first phase of our HCD? First of all, just a bit about the analysis process, because it could be slightly different from maybe what you've observed. We collected data through our research assistants who conducted the interviews and observations. And then what the research assistants would do is they would audio record with the permission of the participant, and then listen back to these recordings and compile detailed notes of the data collection activities, as well as the data that they had collected from the participants. And they were using structured data collection templates for that, so that we could make the analysis process easier. Then this was shared with the analysis team. And so what we did is that we used an online collaborative platform called Miro just to do the analysis bit. And we were transitioning the data that we were getting from the detailed templates into small sticky notes, and you'll see how it looks like in one of the slides that I'll share. So we're transferring that onto the Miro board and looking at them to see what kind of themes are emerging, and what data can we group together into themes, or to start to develop the insights from this data. Then in terms of developing the insights, this again is an insight is a data point. It's more than one data point. So it's a statement sort of you're pulling from multiple data points, describing what the situation is, as well as what is the frustration and what is the need for future, because that's what is now going to inform the opportunities around which you're going to ideate. Then the other artifacts that we developed from the analysis were personas and journey maps, as well as ecosystem maps. Then we shared this analysis outputs, we shared them with the design teams, so as to get more feedback and refine further in preparation for our ideation process. So the way we summarize data, or what we're learning from this kind of research, is we summarize it into what we call insights. And an insight is a nice, succinct statement that captures information from multiple users and information that is coming out more and more. So it's almost like a theme from the data that's telling you this is the situation that is on the ground. So we grouped our insights into these two broad categories, where one category is this one about preferences and experiences shopping online. So under this, we had one of the insights was that women face both structural and preferential barriers to shopping online. And some of the data points that supported these that were coming now from the women is that first, they felt that there's a high prevalence of scammers online, and they were worried of shopping online because of the fear of paying for something and then they don't get it, or what they pay for and what they deliver are totally different things. I'm sure many of us have experienced that in our online shopping activities. Then the other data point was that online shopping remains intimidating for many women, and more so for women who are not familiar with the internet, or who are not familiar with using a smartphone or the computer or navigating the internet. Then another thing that kept coming out is that as much as one is shopping online, there's still that need for a human touch, where you're assured that there's somebody who's looking at what you're requesting for and they understand what you're asking for, and they're going to send to you what you're asking for. And the way this could play out is maybe somebody calls you after you place your order, which is something that Kasha does. They call you and then they confirm that indeed you have placed that order, and then they tell you that it will be delivered and probably within a certain period of time. Then another insight that came out was women shop with particular goals in mind, and they like to buy what they already know and like, and they also want to save money. And some of the things that were coming out from the data were that women want to stick to the brands that they already know and they have used, and they know that this works for me. For instance, for beauty products, for even household cleaning products, they want to stick to a brand that they know, and they would want that their e-commerce platform is offering consistent products, consistent brands and consistent products for them to buy. And of course, in all that, they would like to save as much money as possible. And a lot of the times women cited the current harsh economic times as a reason why they would want to get a bargain or a discount when they're shopping. Then the other broad category of insights was on contraceptive and health resource experiences. So one of the insights was that women want their pressing health needs to be met quickly and conveniently. They don't want to have to wait in line, and that's why some women will prefer to go to an e-commerce platform, because they know that there's no long queue there to buy their oral contraceptive pills, or even to book for a consultation for maybe an IUD insertion. Then women need tailored contraceptive information, largely because they struggle to make informed contraceptive choices when they don't have personalized information or counseling. So if they just find the information has been put in a booklet there, they don't know how that applies to them. So they prefer to have personalized information or counseling. And many women, as much as we're doing research on DMPA-SC, many women had not heard of DMPA-SC. So they would have loved to know more about it before knowing whether it's a product they would want to use. Then specific to young women face unique challenges, such as feeling that they're being judged when they seek contraceptives, especially in the public domain, like in the facilities or in the pharmacy. Because again, we know that the issue of sex, especially among young people and adolescents, is still a taboo topic. And women or young girls face a lot of stigma and judgment around that. Then also another unique challenge for young people is that they don't know how to access or even utilize the available health resources, just because a lot of the work that has been done on contraceptive information and getting the information out there may not necessarily have focused on young people. So in terms of the needs and opportunities that we identified through our research, one is that women need accurate, personalized, and private contraceptive information. And then e-commerce platforms, on the other hand, need to be able to provide quality, consistent offerings, as well as navigable health information and resources. And the other thing that Kasia specifically expressed is that they need to create awareness about the services they offer and the fact that they are offering contraceptive services. Then to encourage women to shop online, one of the opportunities is to create awareness about e-commerce having contraceptives and then provide holistic contraceptive information, including on DMPA-SC, and to provide support options for customers as early as possible in their purchasing journey. Then there's also an opportunity for e-commerce platforms to offer a wide variety of diverse and quality products and to provide incentives and personal support tools for budget shoppers or those who are new to e-commerce. So the rest of our design process largely focused on these needs and opportunities that we identified through our research. I've highlighted, or rather, I've marked in red one need and one opportunity that I'm going to talk about as now I take you through the design steps, which was a need to create awareness about what the e-commerce platform is offering, and for women to know about these products. So other analysis artifacts, I won't go too much into the details of this. As Phoebe expressed, persona it's a fictitious person that is created to represent a group of end users. So it's not one particular person, but we're looking at all the data that we got in terms of who the demographic characteristics, what these women are seeking, what they would want to see, and what frustrates them. You put all that together as a persona. And the reason why you work with a persona is to help you focus your design process or your design work on this person that you're really designing for, so that the solution that you're producing is going to be acceptable and sustainable, or something that can be taken up and be used for a long time. Then the journey map is just a representation of the path a person may take through the interaction with a service. And you'll see that it maps different points of interaction. It connects life activities as well. I think Phoebe's journey map was really detailed and very nice in showing the different things that are happening in this woman's life. Then channels of communication and distribution, as well as functionality, even emotional states of the user at the different time points. So very similar to what Phoebe shared. For instance, one of our personas was this 35-year-old married woman called Jane, who has 2 children and is a business owner. And she wants to use contraception because she doesn't want to have another child. She was using pills and then they failed and she got pregnant with her younger child. So she has a college degree, so it's somebody who can understand various things, can use a computer and a cell phone, but has not shopped online before. And of course, like many women, she's got competing priorities both at home and at work, leaving very little time for herself, even to learn how to shop online. So her overall goal was to have a convenient and easy shopping experience online, so she can save herself time. As you can see here, the last box, personality. I know what I like and I want to make sure I can shop for what I like without wasting time. Remember, she has a lot of competing priorities. And then she also says, as mothers, we're trying to plan our families. We don't want to get those unplanned pregnancies. So it articulates that she is looking for a contraceptive method and she doesn't want to spend a lot of time getting this service. Then in terms of her journey, if she were to shop, let's say on Kasia, so it will start with her deciding that she wants to start using contraception again, and maybe doing some research amongst her friends and hearing, oh, my friend is using this, my friend is using DMPA-SC, so she may decide, okay, I think it's also a good method for me. This happens a lot to many women where they are relying on their peers' experiences and information make a decision about what they're going to purchase. Then once she knows, okay, there's Kasha and I can buy my contraceptives there, she's happy about that because it sounds convenient. She doesn't have to go queuing. And because she's heard about the DMPA-SC, one can buy a whole year's supply, then it sounds like a very good plan for her because she would want to save time and focus on other priorities. So she gets to the Kasha website, but one of the frustrations she might face there is that she has never shopped online. So this is something that is new, even though she has a smartphone. She may take a bit of time to learn the website. And then as she's browsing for a contraceptive, she finds that she knows that she wants to purchase DMPA-SC, but then when she looks at the product description, because she's never heard about it before, she gets overwhelmed because first she learns that she needs to get a prescription, and then also she has to be able to inject herself. This is something that she didn't know about DMPA-SC. So you can see some of the frustration points or the point where the participants or the clients may struggle. Then it's easy for her to choose what she's going to buy because she knows it's DMPA-SC. And she's also happy because she can browse through the different sections to see the deals that are there. And she's able to select some of her favorite beauty products like her lotion, which is on sale. She places an order. Again, it's an easy process for her. She's happy about that. She chooses the delivery time and location and confirms the order. But then at the point between placing the order and getting the product, she's a bit anxious because she's heard about the online scammers and she just doesn't know whether that product will arrive until it finally arrives. And you can see here in number 7, she received the package and immediately checks to make sure that it's correct and that what she ordered is actually what she has gotten, even before she releases the rider who has brought the product. So this Geneva just shows the various points where a woman who's looking for contraceptive and is choosing to buy from Kasha may experience maybe frustrations, and those are points where you can have an opportunity to improve on the process. So in terms of the how might we questions we developed, for us, we had 3, which are very much focused on the insights that we came up with. One of them was how might we leverage Kasha's commitment to high quality products and privacy to create awareness about the benefits of purchasing DMPA-SC on Kasha. Then the second one was how might we encourage budget conscious shoppers to shop on Kasha for all their needs, both health and beauty needs, including contraceptive needs. The last one was how might we provide private non-judgmental information and counseling on DMPA-SC and other contraception so that women can feel educated and empowered when selecting a contraceptive method. So just something small about how might we questions, because again, they're not statements that we may use in day-to-day research. So the reason why they're called how might we questions is just the how means that we're starting from a point where we don't know what the answer is. So again, that's one of the mindsets of HCD, that you're starting from a point of not knowing and seeking to learn as much as possible. Then the might in the how might we, it just suggests that there are multiple options and pathways that the solution could take. And so that's where we now really have room for innovation, because we say don't limit the ideas or the things that you may come up with. It's better to come up with as many ideas as possible. You try them out and then you drop them at that very early stage before you've actually focused on one particular idea and really developed it and used a lot of resources on it. So you fail fast and you fail early. Then the last part, the we, it just means that we are seeking to collaborate on this, both the designer, the implementer or the user, and the stakeholder as well. So now for the last set of slides, I'll focus on that one, the first how might we question, which was how might we leverage Kasha's commitment to high quality products and privacy to create awareness about the benefits of purchasing DMPA-SC on Kasha. And I'll just hopefully try and walk you through the ideation and prototyping and prototype testing phase to see how it really shaped out. So for the ideation, As Phoebe mentioned, for ideation, we have both the brainstorming that is individual and then group brainstorming. And the whole idea is to come up with as many ideas as possible that are addressing the design challenge or the design question that you have. So in this case, for this how might we question, the two main things that the team focused on were to increase awareness about CASHA, because CASHA already exists and they ensure privacy when it comes to contraceptive provision. They ensure that the products they stock and sell are high quality products and that they only get them from the manufacturer. So already that is existing, but do people actually know that CASHA is providing this and that they have that commitment to quality and privacy or that person-centeredness in terms of their care? So that was one of the things they wanted to increase awareness about. And then another thing they focused on was how do people know CASHA? So people want to know CASHA this way, or CASHA would want the clients to know it this way. And that meant that they want to communicate, they have quality products and services, they ensure privacy, they provide support and care to the women or the people who are seeking their products, and their benefits to shopping on CASHA, whether it's deals that are being provided or whether it's the assurance that whatever you order for is actually what you're going to get. So some of the keywords would be something like, you know, we value you and we ensure there is value in the service or the products that we provide through this, that, and the other. We support you, we care about you, and we support you to make an informed choice. And the information that you give us is kept private. So those are some of the things that CASHA would want to communicate, because the women had already expressed the need for this to come out. So this slide, I didn't really, my goal was not for you to try and read each and every sticky note, but it's just to show you how we were grouping the ideas that were coming out. So for instance, there were ideas on awareness creation, maybe if it's offline methods and online methods, how can we phrase the statements online? And if it's offline, what can we use? Is it flyers? Is it posters? Where can we communicate this information or create awareness about CASHA? Where can we talk about CASHA? Could it be social events? Could it be through the mass media? Could it be through social media? So this is just showing how during an ideation, you can have so many ideas coming up, but at the end of the day, you're able to group them into related sticky notes or related ideas so that you form a particular theme. So for instance, here on the right, you can see there were themes around quality, what can be done for quality, and then themes around privacy, support and care, and the benefits. And these were both from the individual brainstorming as well as the group brainstorming. So when we come now to the prototyping, when we come to the prototyping, we'll look at the various prototypes that came from this idea generation process. Remember, we're focusing on awareness creation about CASHA. And one of the things that the team members had, the idea that they had was actually related to, remember there was a weekend where people were going to Naivasha to observe the safari rally, the return of the safari rally after so many years. So there are many viewing points in Naivasha. And one of the young people in the design group said that, you know, that's one of the opportunities where you can really market CASHA and really get people to know that CASHA is there to take care of their reproductive health needs, because the idea is that most of the people who are going for the safari rally would be young people who are probably in the company of their partners, their sexual partners. And it could be that they need, even at a very short notice or in a private way, they would want to access maybe condoms or contraceptive products, or even things like self-test kits, to be able to take care of their reproductive health needs while they are away on this short break in Naivasha. So that idea was phrased as, when going to Vasha, think of Kasha, Vasha being Naivasha. So for that, they felt that the design team that was working on this felt that we need to identify multiple places where Kasha can show or can talk about their products and create awareness about their existence and the services they are providing. And that's how we came up with this journey map, which was to show the various places where Kasha can put awareness creation efforts, which could be at the home, or at the school, for instance, targeting the young girls, young adolescents, and young women. Then at the cyber shop, there's some women who go to the cyber, so they can be targeted there with information. Where there are functions, or what we're calling sherehe, again, information about family planning and where you can get it, and through Kasha can be communicated. And other places that women frequently access include the local small grocery shop, what we call the kibanda, as well as the salon where they go for their beauty treatment, whether it's the spa or the nail technician or for their hair. So these are like multiple places where women can be accessed and they can be given this information about Kasha. So we tested this amongst women as well as amongst service providers in Kasha. And what they really liked about the idea of the journey map is that it targets places that women frequent, and probably even on a day-to-day basis or on a weekly basis. So they felt that in that sense, it would really be able to reach a lot of women with information about Kasha and the fact that Kasha is offering contraceptives, including DMPA-SC. And then because there are different places, like you have schools, you have salons, you have cyber cafe, then you can target different demographics of women. The downside of what they didn't like about it is that it didn't cater for people who don't want to go to social places, or people who don't want to get information about contraceptives through a social place for whatever reason. And then they also felt that this journey map had left out men, yet men are so central to women's contraceptive journeys, even though we're saying that we're talking about self-care products that don't need even the man's consent for her to use the product. But a lot of women have expressed that they want their partners, their male partners, to know or to be involved in one way or another, even though they're not necessarily giving consent. So some of the changes that were suggested. Okay. Some of the changes that were suggested were to add more private spaces to cater for those who may not be going to social places. And for instance, you can put it behind a bathroom door in a hotel or even in a public space. Then add places where both men and women frequent. Some of the suggestions were hotels, brothels, or even places where men would more likely be frequenting, including clubs. Then add internet spaces, e.g. the social media apps. So after refinement of the prototype based on this feedback, this is what we came up with, which was just a map of the possible locations where awareness creation efforts can focus on, which included the school setting, the social media apps, hotels, salons, clubs, the kibandas, and even border sheds. So just diversifying the places and the people that are being targeted for this awareness creation. Then the second prototype that I'll talk about was the one about a branded poster, which went very well with the journey maps, because these posters could be placed in the different locations that had been identified as being high touch points for interacting with women. And here the idea was, again, the idea that came to this was born from a need to give information in a way that is highly visible to women and in a way that does not restrict the awareness creation to just the internet. So both offline and online. Offline being like now those spaces, the physical spaces that we identified, and online being the Kasha website itself and the social media apps that Kasha runs. So one of the thoughts was to have a poster that can be used both online and offline. And you can see here, this is a very low fidelity prototype, meaning that very little resources have been used. You can just see that somebody has handwritten and pasted a picture or printed out a picture of a woman and then put in the details there. And then because the design team felt that a lot of women should get to know about this, there was an inspiration to have a road show where you can have a Kasha branded bus that has information about, hey, if you're in a jam, look no further. Kasha got you for all your personal health products and services that you need. So when we tested this, a lot of the people who we tested this prototype with felt that the phrase "in a jam" is very good because it can spark conversations about contraception. And they also felt, because the poster that we shared with them had a statement saying that Kasha is authorized by the Pharmacy and Poisons Board, they felt that it conveyed legitimacy in terms of the products that they provide. But again, on the other hand, there are people who felt that in a jam could be misinterpreted, especially for maybe older women. They may not necessarily understand what you mean by in a jam. Do you mean in a traffic jam? Do you mean in a jam in terms of something has happened in your reproductive health journey and you need a quick solution? Then as the initial poster had, we had written there that Kasha is available 24/7. Sorry, it's not in that poster. So the Kasha staff felt that this was misleading because they don't work 24 hours. So some of the changes that were suggested were to advertise a mix of contraceptive products on the poster so that it's clear that what we're talking about is contraceptives, and then to broaden the branding to beyond just having it in a bus. So have the posters also displayed in other places like kiosks or other areas where women frequent, and then to reduce the wording and make the details about the Kasha website bigger. So you can see these are second and third iterations of the prototype. To look at it in terms of the evolution of this prototype, you can see that we started from that hand-drawn poster to one where we're sort of branding a bus with the information that was on that poster, and then creating a poster that can be used not just on the bus, but even in multiple other places, and then incorporating the feedback about advertising contraceptive products on the poster and making the Kasha website details a lot more visible, so that it's just very simple that if you're thinking about contraception, you can visit this website or you can dial this USSD code. So a bit about what we did during the prototype testing. It's going back to the field and testing with the end users. In this case, it was the Kasha users, as well as Kasha staff and service providers. And of course, involving the stakeholders just to get their input about the prototypes we had developed. And during the testing, for the poster, the assumptions we made were that it would be a visible item and it would be attractive to potential Kasha customers, and that they would be effective in conveying the message, and that they would lead or they would generate a lot more interest in Kasha. So in terms of the other prototypes that we developed, we won't talk about them, but what we handed over to Kasha, of course, is the awareness creation posters and the journey maps for implementation. Then we had addressing the How Might We question 3 about providing non-judgmental comprehensive information. We had a reimagined DMPA-SC product page on their website, as well as revised contraceptive information flow. Then that was what, based on discussions with Kasha and based on what they had observed through the prototyping and the market, the current market dynamics, they felt that this would be the priority to focus on. Then in terms of the future, if they ever want to introduce discounts, then they could focus on the other prototypes that we had developed, such as offering the bundled packages or discounted hampers, having a loyalty program and card, and additional posters that I didn't talk about. So there was a lot that we generated, but unfortunately I would not be able to talk about all of them. So in terms of the lessons that we learned, very similar to, I'm sure, what Emma and Phoebe talked about. The capacity built through this HCB study is already being leveraged in other projects that we are carrying out, where we're looking at the pharmacy retail channel as being a way to expand access to contraception. Then it's crucial for the implementing partner to be involved from the beginning and throughout the design process, because then they're able to bring in that end user perspective on feasibility and what would be acceptable. Then a lot of data was generated and ideas can be so many. So what helps is to have that persona and the journey map and the ecosystem being like the guiding, the tools that are guiding you to really focus on what the needs were that you had identified. Then of course, HCB, as you've seen, is not a nice, neat and linear process. There's a lot of back and forth. Sometimes you have to go back to the drawing board. So you have to learn to fail fast and move on quickly. And also have that patience and trust in the process that eventually you'll get to the solution that is most beneficial to the users. And of course, don't get too attached to the ideas or prototypes you come up with, because you may take them out to the users and you find that it doesn't work. And that's the whole point of HCB. You want to take it out to the users as many times as possible as you refine it, until you're able to come up with something that will really work for them and that they're really motivated to pick up. So in conclusion, I just wanted to show you where we are in the process. As you can see, we've already done ideation and prototyping, as well as prototype testing and refinement. So currently, Kasha is launching the solutions, or they're preparing to launch the solutions on their website. And then we'll have a program evaluation just to see whether truly these solutions have led to increased access to DMPA-SC and other contraceptives. So I'd like to thank you all very much for your attention. I want to acknowledge the study participants who provided the data, the study teams that have been working on this both in Kenya and other countries, KEMRI, of course, for the enabling environment, and UCSF as well, and BMGF, that's Bill and Melinda Gates Foundation, who are the sponsors of this study. Thank you all very much.
Thanks very much for that, Dr. Gitome. I'm not sure if Mose is with us, but I'll continue on her behalf. Thank you so much for all that information. Indeed, it has been interesting listening to all the interventions that you've been doing in Kenya and using Kasha as a model to deliver the family planning and to meet the family planning needs. So we are going to, because of time, we are going to wind up. And some of the questions, as we give our last comments, we're going to go through just a few questions as we give our last comments. Maybe Julia Kramer, you can give, as you give your last comments, you can maybe comment on the question that has been asked about how the women are able to know about their side effects and ask questions. I know you have answered in one of the questions, but just maybe comment on that.
Yeah, sure. I'll be happy to take a pass and ask my colleagues to jump in as well. But yeah, I think side effects were something that we heard a lot in our research, that there was women had a wide range of side effects that they experienced for different methods. And it wasn't the same for all women, and it wasn't the same across the different methods that they used. So we had a lot of ideas around how we could try to make women aware of what side effects that they could expect. But I think we found that was just such a personal thing, that women would experience different side effects, that we couldn't actually accurately share that information. It would require a much more personalized one-on-one interaction. And so, for example, in the case of Kasha, what we are doing instead of being able to provide that information of side effects is really making sure that there is a trained healthcare provider in the loop. So like Dr. Sarah said, we heard that importance of having a human touch for the e-commerce side, but we also saw that was really important for the side effects management side as well. And so our solution is really focused on how can we connect women with the information they can read on their own, but then also making sure that they know that at any time they need, whether that's in their initial counseling or in their side effect management, that there is a trained nurse that they can talk with through the Kasha platform, who can help them manage any side effects that they might be experiencing, connect them with health resources and any other thing that can help them with their side effect management.
Oh, great. Thank you. Thank you. So there is a nurse on the platform who is able to talk with them. That's very great to know. Emas, you can give us your last comments too from Malawi. How do you see this project being sustainable even in your setting?
Thank you so much. Really appreciate and for other presentations as well. I think for Malawi, one of our great win has been that we've been working with the Ministry of Health, especially the Directorate of the Health. And this is very pivotal in connecting us with the district level stakeholders who are working with the healthy surveillance officers, assistants in the community. So I think as we'll be moving from our analysis phase to ideating possible solutions to the challenges that we are uncovering right now and going to the implementation phase, we are pretty sure of these collaborations to go beyond this current stage. And that I think in the interest of the Ministry of Health, but also the district level stakeholders will be able to help us to sustain and take and scale up the innovations even after the 2 years that is ahead of us. So we are more positive, but also looking out for other possible stakeholders. Just today, even on this call, I was able to get in touch with some other organizations that are working in Malawi that will be interested. They say they'll be interested once our implementation is set. So we are pretty much solid, but also opening our eyes to see what other stakeholders we can engage in when we're implementing our innovations. So thank you so much for giving us an opportunity to share out on our learnings, our processes. This has been so great for us.
Great to hear that from Malawi. Phoebe, you can also give us last comments, anything from Uganda.
Yes, thank you for this platform and for this chance to share all the incredible work we are doing. I think one key takeaway from all this is the family planning services. They have to involve men at whatever point in their journey, because even when the women are not seeking permission, most of them rely on the men for finances, and some of them require transport to these health facilities. In case the FP commodities are out of stock, they do require support, financial support, such that they can access them from private facilities. So it's key for us, even as we do any kind of family planning work, to always think of the men, especially in our setting here in Africa. We live in a patriarchal society, especially in the rural areas. So bringing men on board is always key. And I think we've learned a lot in the maternal journey, reducing maternal morbidity by bringing men on board. So I think we can pick from that and try to engage men as we get onto the family planning journey. Thank you.
Thank you so much for that. We are now coming to an end, and I can say that we have Delis, would you like to also give your comments? I wouldn't like to close you out if you're in a position to. Delis is the director advancing is a director in advancing maternal and newborn child health research, and she's a professor at UCSF Department of Obs-Gyne. Please, if you're able to, you can give us your comments too.
Oh, thank you so much. Good afternoon, and I'll be very brief. I really appreciate everyone's presentations and the insights and the conversation. I think these kinds of approaches that really keep the person at the center and their needs and their challenges are welcome and something we all need to learn from. I do want to just mention that our next session in this series on person-centered care will be focused on respectful newborn care. So I really hope that all of you will be able to join us for that session, which will be next month. So thank you so very much.
Yeah, great. Thank you so much for joining us. Thank you all for your participation. We really appreciate our you panelists for giving us those informative presentation, and we welcome you once again. I can see Martha Kamanga is in. We appreciate you. She gave us a presentation in the last session. So our next presentation, our next session will be next month, exactly a month from now, and we'll send out the dates. It will still be on the person-centered respectful maternal care, now focusing on the newborn care. So we really do appreciate. Thank you, everyone. Do have a lovely evening. Goodbye.